Is the Genomind PGx FAQs Roundtable. You have all of your medical science liaisons here from Genomind. My name is Dan Dowd. I'm the VP of Medical Affairs here at Genomind. And just some housekeeping stuff before we get started. Many of you have already heard this, but if you notice at the bottom of your screen, you'll see a Q&A box. So this is a Zoom webinar platform, which means we cannot see you and we cannot hear you. So if you have a question, put it in the Q&A box and we will answer them periodically. So the point of today's webinar is to answer some frequently asked questions and to put some faces to the voices that many of you hear when you do consults with Genomind. So I'll talk a little bit about our consult platform. We've been doing these consults for about 6 years. We offer clinical consults to anyone who gets a test with us here at Genomind. About a third of clinicians, of new clinicians, take us up on that offer, and we'd like to increase that amount. So part of today's webinar is to make everyone aware that we do offer these clinical consults. When you do these consults, you'll be talking to someone on the team that you see here today. It's a team of PhDs and PharmDs. Now, we've done right around 16,000 of these consults to date. That's over the last 5 or 6 years. So I want to make everyone aware of these consults. We get very high ratings, so we send independent surveys following these consults, and we get ratings above 95% consistently. So we encourage people to take advantage of these consults. The other thing I wanted to do, like I said earlier, is to introduce everyone to our fantastic MSL team. And if you don't know what an MSL is, that's your Medical Science Liaison. They are spread out across the country, and I'd like to introduce everyone to all of our MSLs. So I already introduced myself. If you look at your screen, we're going to work from left to right here, and these are your MSLs in order of seniority. So the second box there, that's Dr. Russell Amato. Now, Russell should be here, but unfortunately, he got hit with the hurricane yesterday. So Russ is without power, so we're going to pinch hit for him today. But Dr. Amato is the one PhD on the team. And, you know, my running joke is that in a team full of PharmDs, our best pharmacologist is actually the non-PharmD. So Russ is a fantastic pharmacologist. He's done more consults than anyone else on the team. And we wish he was here, but him and his family are doing well. We just hope they get power back soon. And Russ is our senior medical science liaison. Our other senior medical science liaison and director of product development is the third person on this list here, and that's Dr. Dan Van Dorn, PharmD. Dan is enjoying some time off this week, so he won't be joining us, but Dan leads a lot of our product development, both PGx product development and our mental health map product development. So beneath Dan there, you'll see Dr. Tori Hoffman, PharmD. So Tori's been with us quite a while. Now, it's kind of hard to pin down Tori, so she came to us from Albany as a new PharmD. She joined our sales team in Long Island and then became an MSL in Philly, got bored with Philly, ended up in Atlanta, got bored with Atlanta, ended up in San Diego. And as far as I know, she still lives in San Diego. So Tori is sort of the clinical face of our marketing department, and we're happy to have her. Next to Tori, you'll see Dr. Harris Wynn. We call Harris Wynn our Swiss Army knife. So in addition to being our MSL in the Southeast, Harris is also sort of the liaison with our laboratory department, doing a lot of quality assurance and analysis with our fantastic laboratory team. Next to Harris, you have Dr. Gabriella Williams. So Gabby also is a PharmD. Gabby is dual boarded, both BCPP and BCPS. And if you don't know what that means, she is a board certified pharmacotherapy specialist. She is also a board certified psychiatric pharmacist. And so Gabby is up in Indiana. She's our MSL for the Midwest, and Gabby's super knowledgeable worked with psychiatric inpatients for a long time, very knowledgeable about different treatment algorithms. And then last, but certainly not least, we have Dr. Seema Patel, who, like myself, is a New Jerseyan, and Seema manages our Northeast MSL territory. So Seema also is a board-certified psychiatric pharmacist, and Seema is heavily involved in product development as well. So we'll talk a little bit about some updates we're making to our pharmacogenetic platform, and Seema has implemented a lot of these changes and also done quality assurance for a lot of these changes. So that's the team right there. Many of you have spoken to these people already, so it's nice now to actually put a face to the voice. The next thing I want to do is introduce everyone to what we have dubbed our golden rules of pharmacogenetics. Okay, so these are the 10 rules that we sort of follow as we're conducting these clinical consults, as we're building new products. These are our golden rules. So I'll go through them briefly because this is always in the back of our head as we're doing anything related to pharmacogenetics. So number one, clinical presentation will always trump any pharmacogenetic data. Okay, so I think sometimes new clinicians will overestimate the impact that pharmacogenetics can have. And we want people to be comfortable with the fact that it's only one piece of the clinical puzzle, and a patient's clinical presentation is always, the most important parameter. With that being said, we think pharmacogenetic data is important. Pharmacogenetic data is probabilistic and not deterministic. There are very few contraindications in pharmacogenetics. As far as I know, I think there's only 3 of them. We can talk a little bit more about them, but for the most part, pharmacogenetics is probabilistic, and we will say things like you are more likely to have side effects to this certain drug. You are more likely to have elevated blood levels with a certain drug. So like most things in healthcare, it's probabilistic in nature. Again, PGx data is only one piece of the clinical puzzle in optimizing drug treatments, and you should never solely rely on pharmacogenetic data to make any clinical decisions. Okay, even with those contraindications, those pharmacogenetic contraindications we talked about before, you would never use that information in a vacuum. It's only one piece of the puzzle. Our patients are partners in pharmacogenetics, and they should understand their results. And patients will ask you questions about this. So we try to educate our patients as well as our providers. And then obviously our prescribers are partners in pharmacogenetics and should understand the results. And that's why we're here today. We should always use pharmacogenetic guidelines when they are available. And we will specifically talk about some of the guidelines that are available. One of the old criticisms of pharmacogenetics was that it wasn't detailed enough, it wasn't specific enough, but now we have some very specific guidelines that are available. We'll talk a little bit more about that later. We should always explain to patients what pharmacogenetics can and cannot do. Patients will overestimate what pharmacogenetics can do. So we always encourage providers to set the baseline. Let the patient know that this will not identify the perfect drug for you. It will try to narrow the treatment range so we can optimize therapy. And when you tell patients that ahead of time, you usually have a better experience. As with all medical fields, these recommendations will change as the evidence grows, and this evidence is growing rapidly. And we weekly will review the literature to make sure we're as current as possible. And our next update should be occurring in the next month or 2 or 3. And we'll be making some of these updates to be more consistent with the current literature. Last golden rule here is that if you use pharmacogenetic data, you must use that information responsibly. Okay, so one of the frequently asked questions we get is what is my legal obligation if I use this pharmacogenetic data? Well, if you have access to this information, we would expect that you follow the most current treatment guidelines if a guideline is available, and use the information responsibly. We'll talk about all of that more in a second. So with all that being said, we have accumulated a list of FAQs. We have about half a dozen very common FAQs that we will go through first. And then we also have a list of about a dozen or so FAQs that have been sent to us, probably from many members of the audience. And then I see there's already 2 questions in the Q&A box. We'll answer them once we're done with that. So I'll kick it off here. I'll start with probably, the most common FAQ we get. And that question is the science legitimate? Is the science supporting pharmacogenetics legitimate? Okay, is it valid? And whenever we get asked this question, we always respond with the 3 bullets that describe the validity or the utility of different type of testing. This mostly comes from the space of diagnostic testing. So there's 3 bullets that we always look at. Is the test analytically valid? Okay, so are the results from the lab true results? Okay, is there a high degree of sensitivity and specificity for the actual results? If the lab says I'm a 2D6 poor metabolizer, am I actually a 2D6 poor metabolizer? Is your lab legit? So that's analytical validity. Clinical validity is the second pillar. So are these associations real? If I am a 2D6 poor metabolizer, does that actually affect blood levels of a particular drug? Okay, clinical validity. And then the last pillar is known as clinical utility. Can pharmacogenetics be implemented in clinical practice? Does it change outcomes? Does it save the system money? Okay, and these are the 3 main responses we will give people when they say, is the science valid? As far as analytical validity goes, our lab is top notch. Just to put some numbers around this, when it comes to pharmacogenetics, we do SNP testing. So we test single nucleotide polymorphisms, and we also test for copy number variants when it comes to 2D6. How many copies of the gene do you have? So when we did some independent validation of our lab, we found that our SNP testing was 99.4% accurate. So when we compared our results to a known result, 99.4% of the times we replicated that. Now with copy number variants, we did the same thing, matched it against a sample of over 2,000 external samples. We had a 99.87% concordance rate. Okay, so if we tested everything just one time, that's the level of accuracy that our lab has. We test every result twice. So we test it again and make sure those 2 results match. And if they don't match, then we do a 3rd test as the tiebreaker. But hopefully what I'm impressing upon you is that there is high analytic validity to the pharmacogenetic testing that comes from our lab. And quite honestly, we hardly ever get questions about that. When people do question pharmacogenetics, it's usually questioning the clinical utility, hardly ever analytical validity. All right, so high degree of analytical validity. Clinical validity would be the next pillar, okay? We will talk about a couple of resources. One is called PharmGKB. So if you ever have questions about the clinical validity of these gene-drug pairs, I would recommend you go to PharmGKB. It's a national database that lists all drug-gene pairs and assesses the associations between a gene and between some type of event. It could be an increase in blood levels, it could be adverse events, it could be response rate or remission rate. And so PharmGKB does a really nice job of ranking these gene-drug pairs by the level of evidence associated with them. There are different levels of evidence for different drug-gene pairs. For the most part, I think it's largely become accepted that CYP450s and these pharmacokinetic genes are widely accepted as having strong associations. It's a little bit of a different scenario when it comes to these pharmacodynamic genes, and I still think people question the clinical validity of these pharmacodynamic genes. Almost every pharmacodynamic gene on our report has a meta-analysis associated with it, or a large GWAS study associated with it. And so we are happy to send out any literature that you may have questions about to support clinical validity. So our medical affairs email is medicalaffairs@genomind.com. So if you have any questions about specific drug gene pair associations, feel free to send that out. On top of that, we will be sending out today's presentation, and we will have a reference slide that has many of the references we've talked about today. If we're missing a reference, send an email to medicalaffairs@genomind.com. Lastly, the last pillar, clinical utility. Is this testing worthwhile? Is there a difference in clinical outcomes if you do pharmacogenetic testing? Okay. There's actually quite a bit of data supporting the clinical utility of pharmacogenetic testing. When there's a lot of data out there, we will usually look towards meta-analyses to summarize the data. When people ask us questions about clinical utility, we will usually reference a couple of meta-analyses. One is known as the Bausman meta-analysis. Another one is the Rosenblatt meta-analysis. Now, both of these are meta-analyses of pharmacogenetic testing outcomes in depression. And remarkably, both of these meta-analyses showed that if you compared tested patients to untested patients, there was about a 70% greater odds of response or remission in the tested group compared to the untested group. So that's a nice resource to support the clinical utility of this type of testing, at least in a depressed cohort. In addition to that, and this is actually hot off the presses from last week, there was a meta-analysis, and I had the name here a second ago. I think, David et al. So David et al. out of the UK published a meta-analysis looking at the cost analyses and also hospitalization rates or rates of medication changes. And the take-home message was if you were to compare a tested cohort versus an untested cohort, there was the odds of hospitalization was about 50% lower in the tested cohort versus the untested cohort. They also looked at changes in medication, and they described changes in medication either as a change in medication or a change in dose or some type of deprescribing, okay? And in the tested group compared to the untested group, you're about 90% more likely to have a medication change with pharmacogenetic testing. So we are happy to point you in the right direction for all of these studies, but hopefully that sheds some light on the clinical utility of this type of testing. So we think we meet all three pillars: analytical validity, clinical validity, and clinical utility. Okay. Now, Dr. Amato was supposed to do this next question, but he's unavailable due to Hurricane Ida. So I will pinch hit for Russell here. And one of his FAQs was, what guidelines are available for applying PGx results to treatment? Okay, and I touched on this a little bit earlier, but I think everyone that does pharmacogenetic testing as part of their practice should be familiar with these guidelines and some of the agencies that publish or support these guidelines. So you may be surprised to know that there are quite a few medications with pharmacogenetic guidance right in the FDA label. Okay, so there are over 300 medications with pharmacogenetic guidance. That guidance could be a dosing recommendation, it could be a cautionary note, it could be some advice about the metabolism of that medication based on the genetic profile. So over 300 medications have this in the label. The FDA has put together a table of pharmacogenetic associations and also a table of pharmacogenetic biomarkers. This is publicly available. So if you, this will be part of the reference sheet that we send out to you. But if you wanted to Google it yourself, this is publicly available information. It identifies all of the current medications that have pharmacogenetic guidance in the label. For example, aripiprazole or Abilify. In the FDA label, it says if you are a 2D6 poor metabolizer, we recommend cutting your starting dose in half for aripiprazole. There's similar guidance on citalopram, atomoxetine, codeine, tramadol. You may remember earlier I mentioned some contraindications, some true contraindications that related to pharmacogenetics. Well, codeine and tramadol have contraindications and black box warnings for 2D6 ultra rapid metabolizers. It's written clear as day in the label itself. Carbamazepine has a contraindication for the HLA-A or HLA-B variants. So those are really the only true pharmacogenetic contraindications in the psychiatry space. There are others outside of psychiatry. But in our space, it's HLA-A, HLA-B, and also 2D6 ultra-rapid metabolizer status. Okay? If you're a positive for any of those genotypes, certain medications are considered off limits under most circumstances. So in addition to the FDA, I mentioned PharmGKB before. PharmGKB is an NIH-sponsored database. They will rank drug gene associations by their level of evidence, and they will clearly score these different drug gene associations. We will be implementing this PharmGKB scoring in our report at some point within the next couple of months. This way we are transparent about the clinical validity of these different drug gene pairs. So check out PharmGKB. In addition to PharmGKB, CPIC, which is the Clinical Pharmacogenetics Implementation Consortium, has a great website where they will list all of their published peer-reviewed guidelines. So the SSRIs have a CPIC guideline. All of the tricyclics have a CPIC guideline. Carbamazepine, oxcarbazepine, phenytoin, atomoxetine, some drugs that probably everyone on this call has prescribed in the past all have CPIC guidelines. And we are happy to share these guidelines with you. They're publicly available on the CPIC website. But if you need some guidance, we can show you where they are. And then last but not least, we review the primary literature every week. We have our internal journal club every week, and we'll review the literature to see what's current. But everyone should be familiar with PharmGKB, CPIC, and the FDA table of pharmacogenetic biomarkers. Okay, so you're probably tired of hearing from me, so we're going to switch gears now and pass it off to Dr. Tori Hoffman, and Tori will talk a little bit about how we can become more educated on pharmacogenetics. So I mentioned Tori is the face of our marketing department, and she has some interesting things to tell you about our educational platform. So Tori, back to you.
Absolutely. Thank you, Dr. Dowd. So one of the questions that we get very often is, where can I find more education on pharmacogenetics and the genes on your panel? So I'll start off with saying that Genomind, again, Dr. Dunn mentioned this, that every test comes with a complimentary clinical consultation to answer any questions that you have about your patient's specific report. So these can be scheduled in advance through our clinician portal, the same place you would go to view the results, or you can call our on-demand consult hotline. Now, in January of 2021, Genomind launched a new educational platform that we call Genomind 360. So every month we host educational events led by our MSL team and a Grand Rounds event led by different guest speakers. The Genomind 360 platform includes clinical articles written by the MSL team, gene spotlights, recordings of all of our virtual events, and more resources. So you can find all of this at genomind.com/360. One of the other great tools that we offer is we'd actually partnered with the Neuroscience Education Institute to provide clinicians with a free CME opportunity. So this was called When, Why, and How to Integrate Pharmacogenetic Testing into Your Practice, which you can get credits for. And the CME is led by Dr. Steven Stahl and can also be accessed right from our Genomind 360 website. So those tools I had mentioned were very specific to our report and our genes on our panel. So for more information about pharmacogenetics in general, I would also definitely recommend CPIC and PharmGKB that Dr. Dowd just went through. So CPIC has really taken on the responsibility of standardizing the field of pharmacogenetics, looking at different terminology, genotype to phenotype conversion tables, and more. So CPIC curates and publishes peer-reviewed, evidence-based, and detailed guidelines to help clinicians really understand how genetic testing results can be used to optimize drug therapy. And again, these are totally freely accessible. You can find them right on CPIC's website. And last but not least, PharmGKB, their database curates all of the guideline information from the FDA, from CPIC, and more. And you can use pharmgkb.org, and you can search it not just by the genes, but also by medications, diseases, or by specific genetic variants. So all of those things are Genomind 360, our consults, CPIC, PharmGKB are all excellent resources to help you feel really good about your education on PGx.
Thanks, Tori. As you were saying that, I just thought about our upcoming CME program with Albany. So I'm going to spend 5 seconds talking about that. So we partnered with Albany College of Pharmacy to develop a pharmacogenetic certificate program. I don't even know if I should be talking about it, but I'm going to anyway. So this launches in 2 or 3 weeks. I'm sure. In fact, I know you will all be getting emails about this once it gets a little closer, but it'll be a 15 credit module to get a certificate in pharmacogenetics. And it has an a la carte option to it where you can pick different modules. Maybe you just want the psychiatry module, maybe you want psychiatry and cardiology. That will be coming very soon. So you'll all hear more about this, but just an FYI to be on the lookout for that. So next, I think we'll go over to Harris Wynn. Harris Wynn. Dr. Wynn's question, or FAQ, is how is PGx testing useful for treating pediatric patients, which is a very common question. So Harris, take it away.
Excellent. Thanks, Dan. May I get the next slide, please? Yeah, so this is a question, as we mentioned, it's here. It's one that we get very often, one that we've gotten so often that we've done a previous grand rounds on it. So linked with the materials that you're going to get after today's session, you're going to get a previous grand rounds, and that was done by Dr. Jeffrey Strawn. And if you're unfamiliar with him, he's a pediatric psychiatrist and associate professor at the University of Cincinnati. They're an institution who is currently implementing PGx, and I highly recommend his presentation as he goes really in depth, very thorough with this topic, way deeper than I can in the time allotted for today. So one aspect of the pediatric population that he mentions is that these disorders of anxiety and depression are some of the earlier ones to emerge. And these rates are rising in children just as they are in adults, and that the patients that you're presumably treating now in your clinic or at your practice, there's a pretty high chance that these disorders or an aspect of them started prior to age 18. And, just like we see with patient-specific factors in adults that can interact with each other, as well as pharmacologic therapy, sex, concomitant medication, comorbidities, lifestyle, genetics, this adds extra considerations in the pediatric population, meaning in the sense that the anxious child at age 8 or age 9 has then a higher chance of being anxious and depressed as a teen or adult, which really emphasizes the importance of getting treatment correct earlier on. Another factor that we're going to consider is going to be demonstrated in that graph in the bottom right, which is that the factors that are going to impact pharmacokinetics in adults, things like absorption, distribution, metabolism, mature at different rates within different age groups of the pediatric population. What we're actually demonstrating in this graph on the right is the differences in cytochrome P450 expression at different levels during development. Now, as Dr. Dowd mentioned earlier, genetics is just going to be a piece of the puzzle. It makes this entire picture a little bit clearer in terms of clinical picture, which is important considering the factors that I've mentioned previously. Now, here at Genomind, this population, the pediatric population, is actually around 20% of our test volume, with the most common age being around 16 years old. As well, aside from Cincinnati Children's Hospital, there's other institutions like St. Jude that do currently implement pediatric testing as well. And may I get the next slide, please? So when it comes to pharmacogenetics, there is going to be several classes of medications that have actionable guidance directly from the FDA, a lot of them which Dr. Dowd have already mentioned, a handful of the SSRIs, ADHD medications like Strattera, some of the second generation antipsychotics, which can be important because antipsychotic weight gain can be more pronounced in this population. Now, it's not just pharmacokinetics either. On the pharmacodynamic side, we're going to see genes like HLA-A and HLA-B with skin reactions, as well as with the mood stabilizers. But other pharmacodynamic genes like SLC6A4 with the SSRIs can be just as important in children as they are in adults. Furthermore, when we're talking about pharmacodynamics, it can call out other factors, non-medication options, things like exercise or L-methylfolate and MTHFR variants when clinically indicated. Thanks, Dan. That's all I had.
All right, thank you, Harris. So next we will move on to Dr. Williams. So Gabby Williams, her question was, which organizations have made statements about using pharmacogenetics in psychiatry? So Gabby, all yours.
Hi, everyone, and thanks for joining this afternoon. So I think this is such an important question to bring up and discuss because over the past recent years, we've seen a number of organizations, groups, and institutions really come forward with supportive statements as it relates to pharmacogenetics, and particularly as it relates to pharmacogenetics in the psychiatric field or in the care of patients with psychiatric disease states. So let's go ahead and start off with the FDA first and foremost. So Dr. Dowd earlier mentioned and referenced the table of pharmacogenetic associations by the FDA, which is a great resource of information as it relates to gene-drug associations. And specifically on that website, the FDA notes and discusses how pharmacogenetic tests, of course, along with other information about a patient and their disease or their conditions, can really play an important role in drug therapy. And furthermore, when a healthcare provider is considering prescribing a drug, knowledge of a patient's genotype can be used as an aid in determining the therapeutic strategy, determining an appropriate dose for a patient, or assessing the likelihood of benefit or toxicity as well. Now, in addition to the FDA, the American Psychiatric Association, or the APA, has also had some supportive statements regarding pharmacogenetics in psychiatry. And some of these statements specifically come from a 2019 document that the APA put together as a comment on a Medicare local coverage determination to cover pharmacogenetic testing. And within that document, the APA identifies that in general, they view several indications as appropriate for pharmacogenetic testing. With some medications, they actually note that pharmacogenetic testing prior to treatment initiation is important to identify whether a patient is at a heightened risk of developing serious complications. And specifically, they note HLA-B 1502 and HLA-A 3101 prior to the initiation of treatment with carbamazepine, oxcarbazepine, and or phenytoin to detect whether patients may be at that heightened risk of those severe skin reactions, things like Stevens-Johnson syndrome or toxic epidermal necrolysis. Now, outside of those genetic testings prior to initiation, they also note that with certain other medications, there's important considerations to be had with the cytochrome P450 enzymes. And they discuss that having that information and information on a patient's genotype as it relates to these P450s can really be important in optimizing medication doses to both limit toxicity or even enhance outcomes based on our knowledge of pharmacokinetics and on these known metabolic pathways. They discuss that particularly in this setting, pharmacogenetic testing can be indicated once a medication is selected for use, or may even be particularly relevant when doses are being adjusted when a patient's already taking a specific medication. Now, in general, they also seemed to concur with the Medicare local coverage determination, stating that pharmacogenomics is considered reasonable and necessary, particularly as an adjunctive personalized medicine decision-making tool. Now, outside of just those comments that were made in 2019, we also see the support of pharmacogenomics and the discussion of the importance of having this information in the newly updated 2020 APA schizophrenia treatment guidelines. Particularly in those guidelines, the APA notes that levels of antipsychotic medications, as well as proportions of active metabolites and other pharmacokinetic properties such as half-life of medications, for instance, can be influenced by genetic differences in metabolic enzyme activity. And they further highlight that specific product labeling for a number of antipsychotic medications refers to that need for dose adjustments based on metabolizer status. So again, really highlighting the clinical utility and the clinical knowledge of how we can utilize this information for our particular patients. Now, outside of just these more US or these more American-based institutions, we've also seen support from international groups as well. And as an example of this, the International Society of Psychiatric Genetics identifies pharmacogenetic testing as a decision support tool in assisting in thoughtful implementation of good clinical care. And specifically, they recommend, again, HLA-A and HLA-B testing prior to the use of carbamazepine and oxcarbazepine. They also go on to state that pharmacogenetic testing, when results are already available to a provider, they encourage that providers integrate that information into their medication selection and dosing decisions. And further go on to, again, highlight specifically CYP2C19 and CYP2D6 and how knowledge on these particular enzymatic pathways could be most beneficial for individuals who've experienced either inadequate responses or adverse reactions to previous antidepressants or antipsychotic medications. And focusing a little bit further on specifically CYP2C19 and CYP2D6, the French National Network of Pharmacogenetics actually recommends that the genetic testing of those two enzyme pathways be initiated prior to initiating antidepressant treatment, specifically in patients that are at a high risk of toxicity. They also highlight that these tests can be potentially used to optimize treatment while also limiting the adverse effects that may come along with these medications. Now, I focused a little bit more so far on more professional-based groups or institutions, but we've also seen some support come from major advocacy groups within the psychiatric space. Specifically in a joint letter that was written in 2019 by the National Alliance of Mental Illness, the National Council for Behavioral Health, the Depression and Bipolar Support Alliance, and also Mental Health America, these groups came together to really identify that the application of pharmacogenetic testing to improve the treatment selection of depression medications is really providing more than just hope to patients. They've noted that multiple clinical studies at that time frame had shown that physicians who utilized genetic information as a part of their treatment decision-making process, of course, were seeing more patients achieve remission compared to those individuals just receiving treatment as usual. And I quote, as they discussed this, they said that this is remarkable. Now, outside of that, they also note that given the public mental health crisis confronting our nation, they believe that healthcare providers should have more access to more innovative tools, including pharmacogenetic testing. So we're seeing a lot of great support too from more of those patient-centered advocacy groups as well. Now, last but not least, I wanted to focus a little bit more on another segment of healthcare, particularly those payer groups or insurance organizations. And in recent years, we've seen positive coverage determinations from several insurance groups. One of them is United Healthcare and also now Medicare, based off of some new local coverage determinations. Now, from a United Healthcare standpoint, their determination notes that the use of pharmacogenetic multi-gene panels can help guide treatment decisions and that it's both proven and medically necessary for antidepressants and antipsychotic medications when certain criteria are met. And among those criteria, it's the inclusion of a patient having a diagnosis of either a major depressive disorder or generalized anxiety disorder, and at least a failure of one prior medication to treat whichever condition it is. Now, furthermore, that Medicare local coverage determination identifies that pharmacogenetic testing is considered both reasonable and necessary in specific circumstances, particularly as an adjunctive personalized medicine decision-making tool. And they further go on to state that there are a number of associated and known gene-drug interactions that have been demonstrated to be clinically actionable as defined by either the FDA or the Clinical Pharmacogenetic Implementation Consortium, or CPIC, as we've talked about previously. They further go on to state that pharmacogenetic testing can be considered reasonable and necessary when the results of that test are necessary for a physician's decision-making process as it regards to either safely administering or dosing a particular medication. And so in total, I think it's really important and really great to see so many organizations come forward and make statements in support of pharmacogenetics and clinical practice. And I think all of us here on the panel today, and probably everybody in the audience as well, hopes to see even more groups, even more organizations continue to show support for clinical pharmacogenetics moving forward as well.
Thanks, Gabby. One of the questions you may have to yourself is, hey, with all these guidelines, how can I keep track of all this information? If you haven't used our GenMed Pro tool, I would recommend that you use that. So GenMed Pro has all of the guidelines built into the software itself. So, if you're ever wondering to yourself, hey, what do I do with this ultra rapid metabolizer? Is this a contraindication? It's built right into the tool, and you'll get an alert there. So if you're worried about your liability in using this type of information, if you follow the guidelines, then you should be in the clear, and all of those guidelines are built into the tool. If you've used our genetic tests in the past, you may have noticed that we often give very specific guidance or recommendations based on certain ethnicities. And so Dr. Patel will talk a little bit about that. So one of the FAQs that she has received in the past is, your report talks about Caucasians and Asians. Why isn't anything else discussed about other ethnicities? So Seema, take it away.
Thanks, Dr. Dowd. Yeah, I think it's a really good question, a common question that we get, but also a really important one. And most of us are probably aware, at least in part, that most of pharmacogenetic studies are done exclusively in European descent populations. That, of course, can make it really difficult to extrapolate these findings to other ethnicities. One of the things that we do here at Genomind is, where there is scientific data, we include those ethnicity-specific results on our test. If there are inconsistent results between different patient populations or ethnicities, we also specify those differences. For example, for BDNF MET carriers of Caucasian ancestry versus East Asian ancestry, there are differing results seen in studies in regards to SSRI response and remission. And you will find those differences in the therapeutic implications section of our report. A couple of other ways that we acknowledge and recognize ethnicity. So HLA-B 1502, Dr. Williams and Dr. Hoffman alluded to this earlier. This is a marker that tends to be more prevalent in Asian populations. It increases the risk of severe skin reactions to carbamazepine, phenytoin, oxcarbazepine, even lamotrigine, which is, I know, a medication that's really widely used in psychiatry. And so having this be more prevalent in East Asian populations, the FDA label for carbamazepine actually recommends testing prior to starting carbamazepine in these at-risk populations. Additionally, the Association of Molecular Pathology back in 2018, they recommended that all pharmacogenetic tests start testing for CYP2C19*35 variants, because it is exclusively found in African ancestry populations and confers a poor metabolizer. So prior to this, we didn't know these patients who were taking 2C19 substrates and breaking them down very slowly. If you're not testing for this, if you're not looking at it, you're going to miss that subset of African ancestry patients who are a really difficult time breaking down these 2C19 drugs. And shortly after that recommendation was done by AMP, we started testing for 2C19*35. So the reason I mentioned that is because even though we're not exclusively specifying that ethnicity in our report, there is behind the scenes acknowledgement of these different allele frequencies among ethnicities that we account for on our report. CYP2C19*35 is just one of them. CYP3A5 is another one. So there are some ways that we acknowledge this as Genomind, but we also recognize that there's just a limitation in the diversity in pharmacogenetic research. Some organizations are trying to remedy this blind spot. So the African Pharmacogenics Consortium, the African American Cardiovascular Consortium. They're doing more research in this population to inform more PGx guided care in African ancestry. PharmGKB, as you can see on this slide, Dr. Dowd and Dr. Hoffman did a really great job talking about who and what PharmGKB is, but they've also created 9 biogeographical groups that you see listed here. And this is really a way to standardize PGx care and also encourage research diversity. If you enter in a drug or a gene into PharmGKB, you will see the list of studies with this gene-drug association, but you also see the specific ethnicities that study was done in based on this categorization. So that way you can at least get an understanding, can I extrapolate these results to other ethnicities, for my patient populations? So, there are a couple of different organizations that are really trying to work around this, and they recognize this limitation. We at Genomind, we look at this, the literature on a weekly basis, and as there are significant findings that come up, we will always make those updates accordingly on Genomind Professional PGx. Thanks, Dan.
All right, thanks, Seema. So now we'll start answering some questions that we received via email or questions that were put in the Q&A box. A couple of questions about supplements. So for now, the only, I guess you would call it a supplement that's on our pharmacogenetic report would be methylfolate. Methylfolate is considered a medical food by the FDA. It's a weird designation. But methylfolate is on our report. There's some pharmacogenetic data relating it back to the MTHFR enzyme. But if you're looking for supplements, we have a sister test called Mental Health Map, which is a direct-to-consumer test. It is not a pharmacogenetic test. It is a consumer-friendly test. And that's really what you would look for if you wanted to learn more about genetic predispositions for traits that may be associated with certain supplements. So in the pharmacogenetic world, and at least on our test, really it's methylfolate would be the only vitamin or supplement. So a couple of other questions that we received via email, and I'm just going to go in the order that we received them. First one was in individuals with the CACNA1C alteration, that's our calcium channel gene. Can you touch on calcium channel blockers or other modalities for stress or mental health? So if you go back a few years, probably 10 or 15 years, there was research into calcium channel blockers for the treatment of mood disorders, mostly bipolar and some for depression. So there is some evidence that calcium channel blockers, things like verapamil or nimodipine, may have some impact on either bipolar or depression symptoms. There's no good data showing that CACNA1C regulates response to calcium channel blockers for psychiatric outcomes. With that being said, if you look into PharmGKB and type in CACNA1C, CACNA1C, you will find several studies related to blood pressure outcomes with calcium channel blockers, verapamil, nimodipine, maybe amlodipine. So you can find that in there, but in the psychiatric space, CACNA1C and calcium channel blockers, there's no direct evidence relating those two. So another question we have, okay, so the question is, what do you do when pharmacodynamic and pharmacokinetic genes suggest very different paths? So that should be rare, and they don't necessarily have to point in opposite directions. So remember, pharmacokinetic genes just tell us about predicted blood levels. It tells us that we expect higher or lower blood levels in an individual. And almost all of the guidelines when it comes to pharmacokinetic genes say you can do one of two things. You can adjust your dose specific for that patient, or you can consider a different medication that doesn't go through that pathway. Okay, so you can think of pharmacokinetics as sort of both drug selection and drug dosing, and you can select either one. So it doesn't have to compete with pharmacodynamic genes, which are often thought of as as guiding drug selection, right? So having a pharmacokinetic gene doesn't have to compete with a pharmacodynamic gene. If you are a poor metabolizer of a certain medication, that doesn't mean you must avoid that medication. It means if you use that medication, you probably want to consider a reduction in dosage. So those two don't have to be mutually exclusive. Even if there's different cautions for a pharmacokinetic gene versus a pharmacodynamic gene, there are very few absolutes. There are very few contraindications in the world of pharmacogenetics. So that should be relatively rare. We received a question about scheduling a consult with the patient. So should I schedule consults with my patients? Completely up to you, and you are welcome to have a patient join the consult with you. So right now, about 10 to 15% of our consults are done with the provider and the patient. We will never do a consult with a patient by themselves because it's not our spot to do that. That is, it's your job as the provider to do that. But if you want to bring your patient onto a consult with us, we're happy to do it with the consult, with the patient on the line. And then we will defer to you as the healthcare provider to make treatment recommendations. So yes, you're more than welcome to bring your patients on board. Okay, let's see what we have. Many questions were answered already in the Q&A box, but let me see if any of them. Okay, so questions about herbal medications, talked about that. Okay, so we'll go back to our emailed questions here. Okay, can you talk a little bit about the validity of tests? The validity of these PGx tests have been challenged by academics. What are their best points? So I think the concern with many academics is that pharmacogenetic testing will steer clinicians away from certain drugs that are completely reasonable to prescribe. And I think that's a valid point. So going back to what we said earlier, I think educating clinicians about the limitations of pharmacogenetics is extremely important. And that's why we have this team of people here to educate on the limitations, right? So if you're making any decision solely on pharmacogenetics, then you're doing it wrong, okay? And we need to tell clinicians and tell patients the limitations of this type of testing. I think clinicians and patients often overestimate this pharmacogenetic information, and it's our burden to make sure they understand what these limitations are. There is, if you're looking at a level of evidence for pharmacodynamic versus kinetic genes, almost across the board, the level of evidence is higher for pharmacokinetic genes. And I think we're at the point now where the clinicians don't generally dispute the pharmacokinetic genes. And if they do, the dispute will be with these pharmacodynamic genes. And the sense I get is that academics don't like the bucketing system that some other testing companies use. They think it's too concrete, and because it's too concrete, red, yellow, and green, it will steer providers away from certain drugs that are completely reasonable, right? If you had somebody with OCD and they had a pharmacogenetic risk for an SSRI, that doesn't mean you need to avoid SSRIs for this person. SSRIs are still a completely reasonable first-line choice, but just use that genetic data to guide you for any treatment failures or any dosing parameters around those drugs. So I think the academics make a good point when they say that very often clinicians overestimate the impact of these drugs and make treatment decisions based solely on genetic parameters, which is not what you should do. Okay, we have a couple of minutes left here. So let's go through some of the other questions. Oh, common question, I'll mention it. Can pharmacogenetic testing tell me which patients will have schizophrenia? or bipolar, or can pharmacogenetic testing predict diseases? I'll give a very short answer. No, it cannot. So pharmacogenetic testing by definition is meant to correlate a person's genetic profile with medication outcomes, and that's it. Now, some of these genes have been associated with certain behavioral traits or certain characteristics, but that's not the same as a diagnosis, all right? Saying you have a genetic predisposition for impulsivity is not the same as saying you have a genetic predisposition for ADHD. So none of the genes on our report, or no pharmacogenes, can predict or will predict your risk for any conditions. Now, we very likely will come to a point in a few years where we develop some type of polygenic risk scoring, where you look at multiple genes and you combine the effects of dozens or hundreds or thousands of genes and create a risk score for a disease. We may say things like, you have a 70% increased risk for bipolar disorder, but we're years away from that, and we can't currently do that with these single gene SNPs that we're looking at now. Okay. So we have another question here in the Q&A box about making treatment decisions based on ethnicities. So, whenever we have data that is conflicting between two ethnicities, we will call that out. Or whenever we have data that has solely been looked at in one ethnicity, we'll usually call that out on a report. I think the gist of the question here is how do you extrapolate that to other ethnicities? And unfortunately, that's a blind spot in pharmacogenetics right now. Okay, I think what tends to happen is if we have data and we have no alternative data let's say we have data in a Caucasian population and we have no alternative data in any other populations. I think what generally happens is we default to the data that we do have. Now, I don't know if that's the right answer or the wrong answer, but the field recognizes this blind spot, and we are building databases, large databases with millions of people across all ethnicities, and we'll have a better answer to that question in a year or two. For example, there's a project called All of Us, and if you want to Google that, the All of Us project's goal is to get genetic data for 1 million Americans, which is representative of the ethnicities of all ethnicities across America. And so we're moving in the right direction. Well, that puts us at the hour. It's 2 o'clock. If we didn't get your question answered, again, our email is medicalaffairs@genomind.com. Feel free to shoot an email to our inbox. We'll do our best to answer these questions. And that's it. We appreciate your attention. This will be emailed out. A link to this webinar will be emailed out to everyone tomorrow. And have a good day. Thanks.